Okay. Assalamu alaikum, everyone. My name is Ismail Abdullah, and today we will be covering the clinical anatomy of the lower limb with some high-yield injuries that we need to know, as well as lower limb nerve injuries. All right, so if you have any questions, just type them out in the chat or feel free to unmute yourselves. طيب. So mainly how we're going to be doing this is we will be having a clinical scenario, and then we'll be discussing the clinical scenario. And from there, we'll be diving more into the discussion about certain high yield topics. We'll be having a total of 19 clinical scenarios where we're going to be talking about fractures, dislocation, ligament injuries, nerve injuries, vascular injuries, and a bit of dermatomes at the very end. All right. So our very first clinical scenario is a 28-year-old male presenting to the emergency department following a high-speed car accident where his knee struck the dashboard. He reports severe hip pain and inability to move his left leg. On physical examination, the left lower limb is shortened, internally rotated, and adducted. The plain radiograph confirms the diagnosis. Okay, so the thing about clinical anatomy in general, starting from year 1 to second and third and even fourth year, is that you need to understand the scenario, you need to identify the keywords so that then you can be able to answer whatever question pops up. So in this scenario, we have a gentleman who crashed, had an accident, and then on physical examination, the limb is shortened, internally rotated, and adducted. Now, this information is enough, but it's also backed up with a radiograph, as you can see here. So what do you think is the structure at the most risk of injury? So first of all, what's going on? So this is a posterior hip dislocation, right? Because as you can see, this is the acetabulum, and the head of the femur is just dislocated posteriorly. So what structure do you think is at most risk of injury here?
I think the sciatic nerve.
Yes, that's going to be the sciatic nerve. That's very correct. Now, why is it not the other structures? It's just simple. This is pure anatomy. The sciatic nerve runs posterior to the the femur. All right. So just the head of the femur being dislocated is enough to cause injury to the sciatic nerve, as you can see here. طيب. Yeah, so again, sciatic and the superior inferior gluteal nerves can be injured, but sciatic is more common because it's more prominent. All right. So this is very straightforward. Moving on. Our second clinical scenario. So we have a 34-year-old long-distance runner presenting with a deep aching pain in the buttock that radiates down the posterior thigh. The pain worsens with prolonged sitting and is relieved by stretching. Neurological examination is unremarkable. What is the likely diagnosis in this patient? So before we start, before we solve the question, this is a long-distance runner. So he's an athlete. Okay. So this is something that we need to know about our patient. Deep aching pain in the buttock. So from the buttock to the posterior thigh. So that's the only range where the pain is being felt. And it worsens with prolonged sitting and is relieved by stretching. Everything else is fine. What do you think is the diagnosis here?
Yeah, I think since he's an athlete, he has hypertrophy of the piriformis, which is basically compressing the sciatic nerve. So
Yes.
it's piriformis syndrome, but does sciatic nerve entrapment also work?
Okay, so first of all, your answer is correct. It's the piriformis syndrome. Now, let me explain to you what actually happens. So as you said, this is an athlete. And in athletes, basically, the the piriformis muscle gets hypertrophied, gets enlarged. And as we know that there's a sciatic nerve coming down, and it needs to pass through the greater sciatic notch. Okay. Now, when the piriformis is there and it's just enlarged, what's going to happen that it's going to compress the sciatic nerve, okay, just enough that it's going to cause the pain from the buttocks all the way to the posterior thigh. If the pain was from the lower back all the way to the foot, then that's sciatic nerve entrapment, meaning that it's fully compressed. All right. Uh, it's not hamstring strain, of course. It's not thoracentric bursitis, because that's uh that's going to cause local pain, not just a full radiating pain. Lumbar disc herniation is a cause of sciatic nerve entrapment. So it's one of the causes, okay? So the right answer is piriformis syndrome. And usually the piriformis syndrome is mistaken for sciatica nerve. Sorry, sciatica, the disease, okay? And yeah, it's about the quality of the pain. So in piriformis, it's just one that's gonna go from the buttocks radiating down the posterior thigh. In sciatica, or sciatic nerve entrapment, or in a lumbar disc herniation causing sciatic nerve entrapment, what's going to cause is going to be a very sharp shooting pain, okay, from the lower back all the way to the foot. And of course, it's going to cause muscle weakness, sensory loss, tingling, numbness. All of these are other findings as well of sciatica. So, yeah, and these are just everything that I just said. All right, are we good to go? So this is our third clinical scenario. So we have a 65-year-old woman presenting to the emergency department with a painful lump in her right groin. She reports that the lump has been present for several months, but has recently become tender, enlarged, and irreducible. Physical examination reveals a firm, tender mass just below the inguinal ligament, medial to the femoral pulse. Which of the following complications is the patient at greatest risk for developing if left untreated? So before we answer, what's really going on with our patient?
She has a hernia
Okay, so she has a hernia. And what makes you think she has a hernia?
because they told us there's a lump on her right groin. She's a old female. It's most
Very good.
commonly femoral hernias for them.
Okay, amazing. Yeah, so basically, this is a case of a femoral hernia, absolutely correct. And since it's a female, it's a risk factor. All right, an advanced age female, it's already a risk factor. Why? Because, females tend to be pregnant, and with pregnancies, especially multiple pregnancies, they get to have weaker pelvis. And in general, they have a wider pelvis compared to male. So it's going to be even weaker. Okay, so they have, due to the weak nature of their pelvis, they're more prominent to be having, um, you know, they're more at risk to having femoral hernia. Okay, so this patient is having femoral hernia indeed. Now she reports that the lump has been there for several months, but it just became tender, enlarged, and irreducible. These are all signs that mean something. Tender, enlarged, we're more thinking of this could be infected, okay? Or this could be incarcerated. Irreducible meaning that maybe they were able to push it back, but now not anymore. It's just there. It cannot go back. So if we need to think that there could be a femoral hernia, what could be the complication that a patient could be that the patient could be developing at a great risk? What do you think?
It could get strangulated and then that part dies off and has to be surgically removed.
Okay, so what do you think? What do you think? One of these options is the answer.
I think bowel obstruction, because if that part dies, then it won't be able
Yes,
to.
correct. That's very correct. It's bowel obstruction. Now, varicocele, hydrocele, it's usually seen in males and not seen in females, especially at this age. Femoral nerve compression is not going to cause uh, it's not going to cause an enlarged, tender, irreducible lump that's painful. Deep vein thrombosis has nothing to do with uh, has nothing to do with the femoral canal and stuff. So yeah, you're right, bowel obstruction. Okay, now what happens is that this is a very nice illustration. As you can see, this is a femoral hernia, and you can see that part of the bowel is, you know, um, I would say leaking outside the abdomen into the femoral canal, right? So what happens, this herniated intestine could develop uh, an infection, especially if it gets, as the colleague mentioned here, incarceration or strangulation. This could cause infection, even necrosis. So if left untreated, it could potentially lead to bowel obstruction, which is very difficult to treat, and so many symptoms could even lead to sepsis. So when these symptoms arise, it's urgent to treat. So let's say that we treated the patient. Okay, let's say that we admitted the patient for a surgical repair. Now, anatomically speaking, which artery is at a high risk of injury during this surgical repair?
I think it's the obturator, aberrant obturator.
Yes, this is pure anatomy. It's even in the slides. So it's the aberrant obturator artery. Cool. Okay, moving on, we have this fourth clinical scenario. So a 45-year-old woman presenting with aching, heavy legs that worsen at the end of the day. On examination, she has prominent, dilated, and tortuous veins along the medial aspect of both legs, with associated skin pigmentation and mild edema. Which of the following is the most likely cause of this condition? So before we answer, this is a woman who just going to work, after work, has these heavy legs that worsens at the end of the day. Okay, and this is basically the pictures of how her veins look at the end of the day. Like, what do you think is going on here?
I think she stands over a long period of time, and
Mhm.
the blood tends to pool in her veins, and the valves fail, which causes the varicosities.
Okay, varicose veins, correct. So the answer here from these options would be chronic venous insufficiency. Now, I think this is just a bit too advanced, but I think it's very nice for you to guys understand what really happens here. Now, the key word is end of the day. طيب. And usually, as our colleague mentioned, that this patient could be standing on her legs for too long. And when you put such pressure, let alone the gravity, all right, this could lead to an insufficiency, all right, in the veins, as the blood is going from the superficial vein all the way to the deep veins, as you can see here. So what could happen, these valves could, dysfunction, leading to blood flow disruption. And then the blood, instead of just going from the superficial vein to the deep vein, is going to start pooling in the superficial vein because there's no proper flow. Okay, will lead to this congestion. All right, which with time, chronically speaking, is going to lead to varicose veins. طيب. And there's also, it's usually associated with the skin pigmentation. Like you will see like a bit of brownish discoloration around the veins. Now, it's not arterial insufficiency for sure, because arteries, if there is an insufficiency in the arteries, that will be like a patient started walking and then started feeling the pain. They could not walk anymore. So they need to stop, rest for 2 minutes, pain goes away, walk again, pain again. In this scenario, it's basically a female who's going and putting, like working, standing too long on her feet, that with time, she will develop varicose veins. Okay. And yeah, let's not go too deep with this one. It's very simple. Just know this picture is varicose veins. Like, sixth scenario. Now, I think it gets interesting. So we have a 24-year-old female competitive skier presenting to the emergency department after a high-speed fall on a downhill slope. She reports feeling a sudden pop in her left knee, followed by an immediate pain and swelling. She describes the incident as her right ski catching in the snow while her body twisted outward, forcing her knee into external rotation and abduction. On physical examination, there's a large knee effusion, marked tenderness along the medial joint line, and significant laxity with valgus stress at 30 degrees of knee flexion. The Lachman test is positive, and McMurray test reproduces a painful click. Before we really dig into the question, this is a patient, all right, who had an accident. And what happened? Her leg got trapped, all right, in the snow. Her body twisted, and then she heard a pop in her left knee. And then the knee went into external rotation and abduction at the same time, all right? And then she presented with a swollen knee, all right? It's very tender. And they did two tests, the Lachman test and the McMurray test. طيب? And they were both positive. What could go wrong in this patient? Like, what happened to her?
I think this is a basic ACL injury. We took the Lachman test that it tests it's the most sensitive test for the ACL integrity. We took another one. We didn't take McMurray, but just from skiing وهيك, it's clearly an ACL injury.
Okay. It is. So basically what happened here, the Lachman test is going to test for what exactly? It's going to test for ACL. And if it's positive, this means we have an ACL tear. McMurray test, when it has a click, it's basically testing for the meniscal tear. If there's any tear in the meniscus, it's going to make a pop or a click sound. So I remember it like M for meniscus. So basically there's a meniscal tear. Now, since the patient already heard a pop, طيب, and basically her knee went into external rotation and abduction, this is a triad of unhappy triad, where we have the medial collateral ligament injured, the anterior cruciate ligament, and the medial meniscus as well. So basically what happened here, we have a high impact force hitting the knee laterally. Tamam? When this happens, this lateral force, okay, is going to cause, of course, with the external rotation of the tibia and the femur, while the foot is fixed, is going to force an abduction and an external rotation. طيب? Remember, her foot is fixed. So imagine, let's say, for example, this is the foot, all right, this is the knee, got a very high impact into it. While the foot is fixed, what's going to happen is that it's going to cause a fixed abduction with an external rotation. And this is going to cause the medial collateral ligament to be damaged or teared. And when this happens, طيب, as you can see here, when this happens, what happens is going to open the knee capsule, the joint space, causing the knee to be prone to more injuries. تمام? Now, normally, the ACL is going to prevent the anterior translation and the excessive internal rotation of the tibia. But what happens here, it's going to rupture as the femur slides posteriorly over the fixed tibia, okay? And that's when we hear the pop. طيب? As the femur continues to slide and externally rotate over the tibia, it's going to tear the medial meniscus, okay? And this explains the unhappy triad, basically. طيب. So this is another question. Basically, same thing, but the only thing that we're saying here that they only had a positive Lachman test, but a negative posterior drawer test. So what do you think is the ligament that's torn in this patient?
Negative posterior drawer basically confirms that it's not PCL. They said he's skiing. It's a positive Lachman test, which tests the ACL, so it's an ACL.
Exactly, that's it. Right, so a 28-year-old male present with a knee pain after sudden twisting injury during a game. All right. He describes a locking sensation and difficulty fully extending the knee. On examination, there's joint line tenderness and pain with lateral rotation of the tibia. What do you think went wrong with our patient? So the key word here is sudden twisting. Okay. And then he's unable to fully extend the knee.
I'm not sure, honestly. Did he injure one of the MSK because it's lateral rotation?
But yes, exactly. Usually, any twisting injury, okay, the first common tear that we face is a medial meniscus injury. طيب. Why? Because the foot is fixed and the femur rotates on the tibia. This usually, most of the time, is going to cause this meniscal tear. طيب. Or again, when there's pain on lateral rotation of the tibia, this also indicates that this is a medial meniscus injury. طيب. So see, there was pain with lateral rotation of the tibia. This is also another finding that you can think of. All right,
بس سؤال,
moving
if it
on.
was pain
Yes,
on medial rotation, would it be lateral meniscus?
could be. Right. And if it was a positive drawer test, it's going to be PCL. All right. Okay, so this is the ninth clinical scenario. So we have a 45-year-old recreational runner presents with a heel pain that is worse when taking the first few steps in the morning after prolonged periods of sitting. The pain is localized to the medial aspect of the heel, worsens with prolonged standing. He reports that his pain gradually improves after walking, but returned with extended activity. He denies recent trauma or known injuries. So what do you think is the cause of patient's symptoms? So first, let's identify the keywords. So this is a runner, طيب. So I could just make an assumption that he's an athlete, okay, or an active person. Of course, I also need to pay attention to the age, 45-year-old. Heel pain that gets worse with few steps in the morning and after prolonged periods of sitting, okay? And the pain is localized to the medial aspect of the heel. And it gets worse when the patient is standing for too long. So what do you think could be the cause of this patient's symptoms?
They're describing the calcaneal tuberosity, so I think it's either going to be a problem with the Achilles or a problem with the plantar fascia. I'm not sure.
طيب. You said problem with the Achilles, right? If there was any problem with the Achilles tendon right now, so if it's Achilles tendonitis, for example, this could mean that there will be a posterior heel pain, not a medial heel pain. Okay. So it's going to be a fully posterior heel pain, not a medial one. And it's going to be worse with calf stretching, not with prolonged standing or like walking, or like, sorry, like if there was an extended activity. So it would not be Achilles. So if you are eliminating, then definitely it's going to be elimination of the plantar fascia, because, you know, it's first of all, this is when, you know, you stand for too long on your heels. Okay. uh, it's one of the common causes of heel pain, plantar fasciitis. طيب. It affects two groups: the young athletes who like overuse it, and older people because of normal wear and tear, like, you know, they're aging and stuff, and like part of life that you walk, you're active, so could also cause it to cause eliciting such symptoms. Now, the thing is, in this is usually uh, this is usually like seen in people who stand for too long, okay, or they walk for long periods. طيب. So this is something very important. Now, if you want to go back to the options right here, could it be a calcaneal stress fracture? It could be, but it should be a constant pain, not a pain that comes and goes. So such fractures is a constant pain. The Achilles tendonitis, we mentioned, it would be a posterior heel pain. Tarsal tunnel syndrome, this is طبعا, it's similar to like carpal tunnel syndrome, where here you have the tibial nerve being compressed. So you're going to have burning sensation. You're going to have pain in the medial ankle. All right. The last one is irrelevant, so don't think about it for now. But yeah, this is inflammation of the plantar fascia causing fasciitis. طيب. I hope it's clear. Yeah. Okay. Moving on, we have a 57-year-old man with a 15-year history of poorly controlled type 2 diabetes presenting the clinic for routine follow-up. So a 57-year-old with type 2 diabetes. He denies any new symptoms, but report a gradual decrease in sensation in his feet over the past few years. Okay. On physical examination, his feet are cool to touch. Monofilament testing reveals a loss of protective sensation. His toenails appear thickened, and there is a small non-healing ulcer on the plantar surface of his left foot, surrounded by callus. He denies any pain on the side of the ulcer. Okay. His hemoglobin A1C is 10.5. طيب. Which of the following is the most important factor contributing to the development of this patient foot ulcer? What do you think?
I think high glucose. We took this like maybe last block or the block before. It
Okay.
forms compounds with proteins. I think they're called age, and they basically cause neuropathy and other problems. They can cause ulcers. He has neuropathy, that's why he can't feel the ulcer. And at the same time, the end stage, the age products from the glucose cause the ulcer.
Perfect. You just summarized it all. So the answer would be diabetic peripheral neuropathy. حلو. Again, as you mentioned, all the symptoms and all the signs just go towards the direction that this is a poorly controlled type 2 diabetes, given his A1C is really high as well. طيب. And again, with glucose being excessive in blood, it's gonna be toxic to the nerves, which with time is going to cause peripheral neuropathy, where the patient does not really feel anything in his foot. That's why they could fall, they're not going to feel pain. They might step on something, they're not going to feel pain. And with time, these ulcers are going to form. And they don't even feel it. Sometimes they won't even notice till they see, you know? So yeah, that's why he denies any pain at the side of the ulcer, due to the peripheral neuropathy. Correct. Okay. Yep. Moving on to our 11th clinical scenario. Okay, so 9 to go, inshallah. So we have a 42-year-old man admitted to the emergency department after his automobile hit a tree, meaning a car, and is treated for pelvic fracture and several deep laceration. Physical examination reveals that dorsiflexion and inversion of the left foot and extension of the big toe are very weak. Sensation from the dorsum of the foot, skin of the sole, and lateral aspect of the foot has been lost, and the patellar reflex is normal. The foot is everted and plantar reflexed. What structure is most likely injured? What do you think?
I think since it's plantar flex, that means the anterior muscles are paralyzed.
Okay.
That's most likely superficial peroneal or superficial fibular. I'm
Okay.
not sure why it's everted. I think you'd have to injure the, what was it, the tibialis posterior and the, was it tibialis posterior? Yeah, it's the same group of muscles, I think. The tibialis anterior also causes the inversion, if I'm not mistaken.
So what do you think? Which answer you're gonna go with?
So I'm looking for superficial fibular. It could be.
But there's also dorsiflexion, like loss of dorsiflexion, and sorry, there is loss of dorsiflexion, loss of eversion, extension of the big toe is weak, so this could point toward that he's losing his his muscle innervation, shui. There's lost sensation of the dorsum of the foot, skin of the sole, lateral aspect of foot, all are lost. The only thing that's intact is the patellar reflex,
So it's
right?
the whole tibial, I mean fibular, common fibular, right?
So,
If it's the whole dorsum, because we took that deep fibular would be just the first web space would lose the sensation. If it was
correct.
superficial fibular, it would be the whole dorsum. You're saying it's the whole dorsum of the foot, so it's gonna have to be common fibular, the whole nerve.
So, what's your answer? A, B, C, D, E.
I'm still not sure. The choices in it, they're indirect, all of them.
طيب. Let's exclude one by one. حلو. Let's start with E. If there was tibial and nerve injury in the popliteal fossa, what's going to happen?
He would lose his gastrocnemius muscle, and his foot would not be. It would not be just
So no
plantar
dorsiflexion and
flexed.
no inversion.
No, if he lost his tibial nerve, he wouldn't do plantar flexion. He would be able to do dorsiflexion. It's
Good,
the opposite
exactly.
here.
Yes, correct. Meaning that the dorsiflexion and the inversion are going to be intact. صح?
Yeah, صح.
So E is not the answer. طيب. If it's the sciatic nerve injury at the doorway to the gluteal region, like for example, there will be more of sensory loss to the foot, sorry, not the foot, the lower limb in general, and there will be more of muscle weakness. He's only having weakness in dorsiflexing, inverting, and extension of the big toe. These are the only muscle weakness that the patient is going through. And not the full skin is like there's not full sensory loss. So it wouldn't be sciatic nerve, because if it was sciatic nerve, there will be more sensory loss and more muscle weakness compared to what he presented with. طيب.
It
If we
has to
go
be
with
C.
طيب, if you go with
Has to be
C,
C.
tell me.
Fibular division of the sciatic nerve. You just said if the sciatic nerve was injured before it was dividing into the common fibular and tibial, obviously all the muscles under the knee would be paralyzed. He wouldn't have a what was it, a plantar flexed foot because he wouldn't be able to do dorsiflexion or plantar flexion. It would be a flail foot.
Okay, cool. But can you explain to me, if you chose C, can you explain to me the loss of sensation at the sole of the foot?
If it's at the okay, sole of the foot is tibial.
So
So
it's not C.
so it has to be yeah, صح صح.
So now let's go B and A. هلا it's either one of them. حلو. طيب. B, it says L5 and S1 spinal nerves torn at the intervertebral foramen. Could be. Could be, صح?
Could be.
But what's the thing that in the question right now that would make me say that B is wrong?
It's a pelvic fracture.
Still, pelvic fracture could maybe the trauma was really strong. He could have, had a spinal injury too.
He has the patellar reflex, which means the quadriceps is
Exactly.
innervated.
That's correct. So the answer is going to be the lumbosacral trunk at the at the linea terminalis. Because this level is going to, so at this level, we're going to have the common fibular and you're going to have tibial. which explains the mixed sensory and the motor deficits the patient is having. طيب. And this level, okay, with طبعا the lumbosacral trunk at the linea terminalis is L4, L5. حلو. This level right there spares the femoral nerve, meaning the patellar reflex is going to be normal, which is why B is wrong. لأنه you need S1. طيب. You need L5 and S1. A is L4, L5. صح هو حياتي common fibular with tibial explains everything here. ماشي. But again, femoral nerve will be spared. That's why patellar reflex is normal, which is why we go with this answer. It's very important, especially يعني بالupper والlower limbs. It's very important to know the levels. لأنه يعني you need to know the levels and what exactly from each level, what kind of nerve comes out. This is يعني very, very important. So I feel in this question like highlights that importance. So yeah. Did you get it?
I have a question. So he
Yes.
lost the sensation at the sole of the foot, which is from the tibial nerve. But at the same time, the motor innervation of the tibial nerve is fine.
مو شرط يكون fully fine. He had mixed motor deficits and sensory deficits, but not full loss. Okay. The structure injures يعني شوي من النيرفز بس مو شرط انه يكون عنده full loss.
So A means that the lumbosacral trunk is hit and any random, basically, nerves coming from it got injured.
Sure. But the takeaway of this question is you need to know the levels of where the nerves are originating from. ماشي. The other takeaway is that you need to know the function of the nerves. حلو. So not really how much damage has been there. طيب. You just need to be able to eliminate them accordingly. ونحن we explained it يعني. يعني هلا مثلا this patient could have way more sensory loss if his sciatic nerve was injured. طيب. So it does not really mean إنه والله يعني if إذا مثلا شوي ضل like a bit of motor was intact, also depends on how يعني the timing of the injury. And if it's so many details. So the thing here from such questions, if this question pops in the exam, for example, you need to be able to eliminate it. And like you need to be able to identify what's special for each and every nerve. يعني مثلا انت you're almost gonna say, the answer is C, fibular division of the sciatic nerve, which I almost agreed to. But again, skin of the sole, it's not supplied by the fibular division. عرفت كيف? Which makes me think, oh لا خلاص, this is not the answer. You see where I'm going at?
I have just one more question. You said
Yeah.
B is wrong because the patellar reflex is normal, indicating that the femoral nerve is okay. The origin of the femoral nerve is L2, L4, and B says L5, S1.
طيب.
Oh, it's just confusing how that has to do with the femoral. I think it's unrelated.
I'm gonna look into it, but what I think about right now, it's لأنه femoral nerve is like spared. That's why the patellar reflex is شو اسمه, it's normal, is intact. But I'm gonna let you know. Okay. طيب. Let's move on. Okay, so moving on to our 12th clinical scenario. So we have a 72-year-old woman admitted to the emergency department after an episode of stroke. During the neurological examination, the patient shows no response to the ankle reflex test. Which of the following nerve roots is responsible for this reflex? What do you
It's
think?
just recall tibial nerve is S1, S2, so S1.
Yes, so it's going to be S1 and 2 is correct. So it's going to be E. Nice. But 13. So we have a 45-year-old intoxicated male struck by a tour bus while walking in the middle of the street. The man was admitted to the emergency department and during physical examination was diagnosed with scissor gait. in which an individual crosses one limb in front of the other. Okay, as you can see right here. There's like a bit of internal like adduction, rotation as well. So this was due to a powerful hip adduction. طيب. He cannot feel anything on the medial thigh upon physical examination. Which of the following nerves was most likely involved in this condition?
I think because medial thigh and powerful hip adduction has to be obturator.
Correct. Yes. Nice.
But I don't understand why he has the scissor gait.
It's because he cannot adduct. He cannot adduct his hip. And from the side of the injury, he cannot adduct his hip, which is why he's going to walk with one limb crossing the other, which is known as a scissor gait. But the other thing that could also help you identify why it's the obturator is because he also cannot feel anything on the medial thigh. You got it?
Isn't hip adduction when they bring their like legs together? But here he's like, you could say medially rotated. And to laterally rotate, he would need the, I think, piriformis, because that's one of the supinators along some others. But I think, as you said, yeah, the sensation is probably enough to answer the question.
Yep. Okay. I don't even think that the scissor gate is in your is covered like in explaining the obturator nerve injury. But this is like a good example because some questions are just going to tell you that he's crossing one limb in front of the other. Because this came in my exam back in when I was in first year. They didn't even mention that the patient had sensory loss over the medial thigh, but just the idea that crossing one limb in front of other, because he had a very powerful hip adduction. This is like a takeaway, if you see it in a question, that it's an obturator nerve injury, and of course the medial thigh. طبعا. Okay, so 14. Sorry, apologies for the number here. So it's a 55-year-old woman bitten by a dog in the dorsum of the foot and was admitted to the emergency department. The wound is cleaned thoroughly, during which it is seen that no tendons have been cut, but the dorsalis pedis artery and the accompanying nerve have been injured. Which of the following conditions would be expected during physical examination? Club foot, foot drop, inability to extend the big toe, numbness between the first and second toes, weakness and inversion of the foot.
I
What do
think
you think?
the numbness between the first and second toes, because that's where the dorsalis pedis artery is.
Okay, but which nerve is affected here?
That's deep fibular.
Correct. So if you see the picture right here, طيب, this is your deep fibular, innervating the web space between the first and the second toe. And this is the dorsalis pedis. So let's assume the dog bit her right here. طيب, this is what's really affected. It wouldn't be club foot because club foot is something congenital, something you're born with. Foot drop, if there was damage to the common fibular nerve, all right, more proximal, then it could be a foot drop. Inability to extend your big toe, that would need the what was the muscle called? The extensor hallucis longus to be injured, sorry. And weakness and eversion of the foot. Here you would require the tibialis posterior and tibialis anterior, which is basically tibial nerve and the deep fibular nerve. So this is why the answer is going to be D. طيب. And if you want to also work by elimination. Okay, 16th clinical scenario. So we have a 20-year-old college student receiving a severe blow on the inferolateral side of the left knee joint while playing football. Radiographic examination reveal a fracture to the head and the neck of the fibula. Which nerve will be injured?
It's common peroneal or common fibular.
Correct. Common peroneal. لأنه it runs exactly in the back, but then it divides. حلو. How will the patient present upon physical examination? Like how will you see him when he comes into the clinic?
foot drop and an inverted foot because both deep and superficial are شو اسمه, gone, and he's gonna have loss of sensory in all of the dorsum of the foot.
Exactly. Foot drop, inverted foot, and loss of senses on the dorsum of the foot. Nice. But now, 17th clinical scenario. So this is a 35-year-old woman presented with shooting pain down the back of her leg after receiving an intramuscular injection in her buttocks. On examination, she has weakness in both plantar flexion and dorsiflexion, and her foot hangs loosely when lifted off the ground. What nerve is injured?
The sciatic nerve.
What's your keyword?
She has flail foot, which means no dorsiflexion,
No,
no plantar flexion,
before the picture.
but
What's the keyword in the question?
intramuscular injection in the buttock.
Okay. And shooting pain, which is going from the back of her leg. طيب. يعني going down the back of her leg. Intramuscular injection. كل هدول indicate إنه في sciatic nerve injury. And this is known as flail chest, as you mentioned. Correct. طيب. So this is a 32-year-old male undergoing a posterior hip dislocation after a motorcycle accident. On physical examination, the patient stands on his right leg and his left hip drops. He also has difficulty abducting his thigh on the affected side. What is the structured injured?
I think it's the right superior gluteal nerve.
Okay. And what is the sign elicited in the figure?
That's the Trendelenburg sign.
Yes, Trendelenburg sign. And what muscles are paralyzed?
Gluteus medius and minimus.
Yep, nice. طيب. Wait, is this? Okay. Ignore the picture. This is a mistake. A 45-year-old patient recently fell, got his hip dislocated. A few days later, he presented with difficulty climbing stairs and standing up from a seated position following a posterior hip dislocation. He denies sensory deficits, but has weakenings in his hip extension. What is the structure injured?
I think it's the inferior gluteal nerve.
Inferior gluteal nerve, correct. Because, what's your keyword?
Hip dislocation and difficulty climbing stairs.
Yes, difficulty climbing stairs and even standing up from a seated position. Also, because due to the posterior hip dislocation, these are all indicators that the patient had an inferior gluteal nerve damage. But why is he having difficulty climbing stairs or even standing up?
Because the gluteus maximus is weak or paralyzed.
Yeah, that's correct. And that's about it. Thank you very much for attention. I hope I was able to refresh most of the high yield concepts in clinical anatomy of the lower limb. If you have any questions, please don't hesitate to reach out and you can leave your feedback here. Thank you so much. Thank you, Khalsa, for hosting the session.